Brand new, shocking research out of 2026 is turning everything seniors have been told about blood pressure completely upside down. Something about the number your doctor has been chasing for years. The number on the chart with the green check mark next to it. The number that means you are doing well, you are on track, keep taking your pills. But there is a very high chance that number is not just wrong for your age. There is a very high chance that chasing it has been quietly starving your brain of the oxygen it needs to stay sharp. And nobody told you that the guidelines it came from were never tested on people over 65. By the end of this video, you will know exactly what the new 2026 age-specific guidelines actually say, what the safe range really is for someone your age, the one number on your reading your doctor is not watching closely enough, and the 4 natural interventions that work with your aging arteries instead of against them. This is the complete picture your 15-minute appointment has never had time to give you. Stay with me, because this starts with a woman named Dorothy. Dorothy was 73 years old. She lived in Savannah, Georgia. She had been on blood pressure medication for 11 years, and in all 11 of those years, she had been what her doctor called a model patient. She took her pills at the same time every morning without fail. She had cut back on salt. She walked her neighborhood most evenings after dinner. She went to every follow-up appointment and sat in the waiting room with her reading glasses and her crossword puzzle without complaint. Her blood pressure at her last 3 appointments had been 118/62, 122/58, and 116/64. Her doctor looked at those numbers and said the words Dorothy had been working toward for over a decade. He said, "Dorothy, your pressure is textbook. Whatever you are doing, keep it up." Dorothy kept it up. 6 months later, she could not remember where she kept her car keys. Not once in a while, every single morning. She stood in her kitchen trying to reconstruct where she had been the night before, retracing her steps, checking the same 3 spots on the counter. She mentioned it to her daughter on the phone. Her daughter said it was stress. She mentioned it to her doctor. Her doctor said it was normal at her age. She started having trouble with words. Not the wrong word. No word at all. She would be telling a story and hit a blank where the word she needed should have been. She knew the word existed. She could feel the shape of it, but it would not come. She began leaving more gaps in her sentences, hoping the listener would fill them in, and feeling something close to shame when they could not. She fell twice in 4 months. The first time, getting up from her recliner in the morning, a brief dizziness that sent her into the wall. The second time, on the back porch steps, a stumble that left her sitting on the bottom step for 20 minutes before she felt steady enough to stand. She did not tell her daughter about either fall. She did not want to have the conversation she knew would follow. She came to see me because her neighbor, a woman she had known for 15 years, had watched her pause at the curb outside the pharmacy for almost a full minute before stepping down. And the neighbor had said, gently but clearly, "Dorothy, something is not right. You need to go see someone." When I looked at Dorothy's chart, her blood pressure numbers were beautiful. Every reading in the past 2 years was exactly where the guidelines said it should be. And I knew immediately what had happened to her. Dorothy did not arrive at my office the way most patients do. She did not come because something dramatic had happened. She came because a neighbor noticed something she had stopped noticing about herself. And that is one of the hardest things about what chronic low cerebral blood flow does. It does not announce itself. It does not arrive with chest pain or a sudden collapse. It takes things quietly, one word at a time, one key at a time, one moment of hesitation at a curb that would not have been there 3 years ago. Her daughter had noticed before Dorothy had. Daughters often do. 6 months before Dorothy came to see me, her daughter had mentioned on a phone call that her mother seemed tired lately. Not physically tired, a different kind of tired, like something was running on lower power. Dorothy had brushed it off. She was 73. Some slowing down was normal, but her daughter kept a mental note of the things she observed on her monthly visits. The half-finished crossword left on the side table. The same story told twice in one afternoon. The moment Dorothy reached for a word in the middle of a sentence and paused, and her daughter watched her mother's face go somewhere private and effortful and come back without the word. Her daughter did not say anything during those visits because she did not want to frighten her mother. She waited. And when Dorothy called her after the neighbor's comment at the pharmacy curb, her daughter said, "Yes, please go. I have been waiting for you to say that." That is the other cost of a brain being slowly starved that never gets measured in a clinical trial. Not just what the patient loses, what the people who love them watch happen. Dorothy's experience is not rare. It is not dramatic. That is exactly why it gets missed. A stroke makes itself known immediately. Chronic low cerebral perfusion does it quietly, day by day, word by word, until someone who loves you notices the person inside you flickering. I see this pattern often enough that I have stopped being surprised by it. A patient in their early 70s with beautifully controlled blood pressure on paper, a doctor pleased with the numbers, a patient who has done everything right, and a slow, quiet erosion of the things that make daily life feel like their own. The crossword puzzle that takes longer. The phone call where they lose the thread. The walk to the car that requires a little more concentration than it used to. These are not symptoms of aging. They are symptoms of a brain that is not receiving enough blood flow. And in many cases, the very medication managing their blood pressure is the reason why. That is not the medication's fault. It is doing what it was designed to do. The problem is that it was designed based on data from people who were younger and whose brains and arteries worked differently. Your brain at 75 does not work like your brain at 67. Your arteries at 75 do not behave like your arteries at 67. The 8-year difference matters more than you might think. It is not your fault if this is the first time you are hearing this. Your doctor is following the guidelines they were trained on. Those guidelines were written after a large trial called the SPRINT trial in 2015 that pushed for aggressive blood pressure lowering, down to 120 systolic, for high-risk patients. The trial showed cardiovascular benefit. It was celebrated. It became the new target. What the celebration did not always include was this. The SPRINT trial excluded people with a history of stroke, excluded people with dementia, and the average age of participants was 67. Not 75, not 80, 67. And the physiology of a 75-year-old brain and a 67-year-old brain are not the same thing. The newer 2026 consensus data has now confirmed what some cardiologists had been warning about for years. For seniors, particularly those over 70, there is something called a J-curve. Picture the letter J. As blood pressure comes down from very high levels, risk of heart attack and stroke drops. That is the left side of the J, going down. Good. But if blood pressure is pushed too low, the right side of the J curves back up. Mortality increases. Risk of cognitive decline increases. Risk of falls increases. The bottom of that J, the safest point for most seniors, is not 120. For many people over 70, it is closer to 130 to 140 systolic. Not higher. That range. And the difference between landing there and being pushed to 118 can be the difference between a brain that is being adequately fed and a brain that is slowly being starved. Comment below right now and tell me what your last blood pressure reading was. Both numbers, top and bottom. I want you to see something about your own numbers before we go any further. Now let me explain what Dorothy's doctor was not watching, and why missing it cost Dorothy her car keys and her words and 2 falls in 4 months. When you look at a blood pressure reading, there are 2 numbers. The top number is called systolic. That is the pressure when your heart squeezes and pushes blood out. The bottom number is called diastolic. That is the pressure when your heart relaxes between beats. Most of the attention in blood pressure management goes to the top number. Lower the top number and you have done the job. But for seniors, the bottom number is where the real danger hides. Here is something most people have never been told about their own heart. Your coronary arteries, the vessels that feed the heart muscle itself, only fill with blood during diastole, which just means they only fill during the moment when your heart is resting between beats, not when it squeezes, when it rests. That is the only window the heart has to feed itself. If your diastolic pressure, the bottom number, drops below 60, that window closes. The heart muscle cannot get enough blood to feed itself during that resting moment. It starts to starve. Quietly, without dramatic symptoms. Just a slow, silent starvation of the muscle that is keeping you alive. Dorothy's bottom numbers were 62, then 58, then 64. Her doctor was watching the top number come down to 118 and calling it textbook. The bottom number, at 58, was below the danger threshold. Dorothy's heart was fighting to feed itself every single night, while her chart looked perfect. Now here is what was happening to her brain. Your brain sits at the top of your body. To get blood up there, your heart has to push it against gravity. In a young, elastic artery, this is easy. The artery stretches as the blood comes in and then springs back, maintaining steady pressure all the way up to the brain. In a senior with stiffer arteries, which is almost everyone over 65 to some degree, that spring is weaker. The artery cannot maintain pressure as effectively. The brain depends on a higher baseline pressure to get adequate blood flow, especially to the deep white matter, the regions responsible for memory, word retrieval, and executive function. When you take that already stiff artery system and push the pressure down to 118 systolic, you are reducing the driving force, pushing blood to the brain, below what those stiff pipes need to deliver it. The blood reaches the surface of the brain reasonably well, but the deep structures, the white matter, the regions Dorothy needed to find her car keys and finish her sentences, those regions start receiving less and less. Think of it like a sprinkler system in a large garden. The sprinklers closest to the pump get plenty of water. The ones farthest away, at the very back corners of the garden, depend on the pump pressure staying high enough to push water all the way out to them. Drop the pump pressure even slightly, and the back corners start going dry. The roses in the front still look fine. The plants in the far corner slowly die of thirst. Dorothy's deep white matter was the back corner of the garden. A study published in JAMA Neurology found that seniors with consistently low diastolic blood pressure had significantly more beta-amyloid plaque in their brains. Beta-amyloid is the substance most closely associated with Alzheimer's disease. Why? Because the brain has a cleaning system called the glymphatic system that flushes waste products out of the brain tissue at night while you sleep. That cleaning system depends on adequate blood pressure to function. When pressure is too low, the cleaning system slows down. The waste, including beta-amyloid, accumulates instead of being flushed out. The brain that is being medicated to look good on a chart may be accumulating the very plaque that causes dementia. Dorothy did not have Alzheimer's. Not yet. What she had was vascular dementia, the slow shrinking of the brain from chronic low oxygen, from years of the back corners of her garden going dry. Some of it was reversible. Some of it was not. That is the honest answer, and she deserved to hear it. But here is what I also told her. We can stop the progression. We can find her the right pressure for her age and her arteries. And we can do it in a way that protects both her heart and her brain at the same time. Before I tell you how, I want to explain something called pulse pressure. Because this is the number that tells you more about the health of your arteries than either the top or bottom number alone. Take your systolic, the top number, and subtract your diastolic, the bottom number. That difference is your pulse pressure. A reading of 120/80 gives you a pulse pressure of 40. A reading of 170/60 gives you a pulse pressure of 110. A pulse pressure of 40 means your arteries are elastic. They stretch and spring back efficiently. A pulse pressure of 110 means your arteries are stiff, like old lead pipes instead of rubber garden hoses. The blood comes in. The pipes cannot spring back. The pressure swings wildly between beats instead of staying steady. Here is the trap that pulse pressure reveals. A doctor sees a reading of 170/60 and treats it. The medication works. The new reading is 130/40. The top number looks so much better. The doctor is satisfied. But look at the pulse pressure. It was 110 before. It is still 90 now. The stiffness has not changed. The medication just lowered the overall flow. And a diastolic of 40 is not a number to be satisfied with. It is a number to be concerned about. The goal is not just lowering the top number. The goal is improving the elasticity of the arteries so that both numbers move in the right direction and the gap between them narrows over time. And that requires addressing what is making the arteries stiff in the first place. Subscribe now if you have not already, because what I am about to describe is a symptom that many people over 65 have been told is a prostate problem, or a bladder problem, or just aging, and it is none of those things. Comment below and tell me how many times you wake up at night to use the bathroom. Just the number, because your answer is directly connected to your blood pressure profile in a way that nobody has probably explained to you. In a healthy person, blood pressure drops 10 to 20% during sleep. This is called nocturnal dipping. The arteries get a break. They rest. They repair. Blood pressure doing its job quietly in the background while you sleep. In seniors with stiff arteries, this drop often does not happen. They are called non-dippers. Their blood pressure stays elevated all night long, sometimes even rising. The arteries never get their rest. The repair that is supposed to happen during those hours does not happen. The kidneys, sensing high pressure all night, do what kidneys do when pressure is elevated. They try to reduce fluid volume to bring the pressure down. They produce more urine. You wake up to use the bathroom. Then again. Then again. Not because something is wrong with your bladder, because your blood pressure never dipped the way it was supposed to, and your kidneys have been working overtime all night trying to compensate. Let me give you a clearer picture of what non-dipping looks like in daily life, because most people who have it do not know they have it, and the symptoms are easy to attribute to other things. You wake up in the morning feeling like you barely slept, even though you were in bed for 8 hours. You feel a heaviness behind your eyes first thing in the morning that lifts slowly over an hour or two. You wake up multiple times to use the bathroom, not because you drank too much water before bed, but because your kidneys were working overtime trying to reduce your blood pressure by eliminating fluid all night. Your morning blood pressure reading is sometimes higher than your evening reading, which seems backward and is backward, because a normal blood pressure profile should be lowest in the early morning hours. If any of those descriptions sound familiar, you may be a non-dipper. And the 3 times higher stroke risk associated with non-dipping is driven by the fact that arteries that never get their nightly rest period accumulate damage faster. The microscopic repairs that are supposed to happen during the pressure drop window of the night do not happen, year after year, night after night. The Hibiscus Tea protocol I am going to describe later targets this specific window. Taken in the evening, it supports the natural pressure reduction that should be occurring during sleep. It is not a sleeping pill. It is not a sedative. It is a gentle, evidence-based intervention aimed specifically at the hours when your arteries are supposed to be recovering. Non-dippers have 3 times the stroke risk of people whose pressure dips normally overnight. 3 times. And the solution is not a bladder medication. It is addressing the arterial stiffness that is keeping the pressure elevated through the night. Now I want to tell you about ibuprofen and naproxen. Because if you have been taking either of these for joint pain, for a sore back, for the aches that come with being over 65, you need to hear this clearly. These medications, which most people think of as harmless over-the-counter pain relievers, block enzymes in the kidneys called COX enzymes. Those enzymes are part of how the kidneys regulate blood flow and fluid balance. When you block them, the kidneys panic slightly. They start hoarding sodium. Sodium pulls water. Water increases volume. More volume means higher pressure. Studies have shown that taking an NSAID regularly can raise your systolic blood pressure by 5 to 10 points, which just means your blood pressure medication may be working perfectly, and the ibuprofen you take every morning for your knee is quietly undoing everything the medication does. They are in a tug-of-war inside your body, and you have no idea it is happening. There is a second medication trap I need to tell you about. For the men watching, if you take a prostate medication called tamsulosin, which most people know as Flomax, and you are also on blood pressure medication, your risk of orthostatic hypotension increases by 40%. Orthostatic hypotension just means your pressure drops dangerously when you stand up. Both medications lower blood pressure through different pathways. Together, they can lower it too much, too fast, at the moment you stand up from your chair or your bed. A hip fracture in a senior carries a 30% mortality rate in the first year after it happens. 30%. 1 in 3 people who break a hip after 65 do not make it through the following year. Falls from medication-related dizziness are one of the most preventable causes of that fracture, and most people taking both medications have never been told about the combined effect. The active stand test. Here is something you can do at home today that costs nothing and takes 3 minutes. Sit quietly in your chair for 5 minutes. Take your blood pressure while sitting. Write it down. Stand up. Take it again immediately. If your systolic drops more than 20 points when you stand, you are already over-medicated. Your body cannot compensate fast enough for the positional change. That is not a normal finding. That is information to bring to your doctor at your next appointment. If you found the active stand test useful, subscribe now so you do not miss the next video. I am covering something that directly connects to everything you just learned about diastolic pressure and nocturnal dipping, and it explains why so many seniors on the right medications are still not sleeping well. Comment below and tell me if you have ever done this test at home, or whether your doctor has ever tested your standing blood pressure alongside your sitting reading. Many people go years with every reading taken in the same seated position, without ever knowing what happens when they stand. Now let me tell you about Dr. Walter Kempner. Because he proved something in the 1940s that changed medicine forever, and most people have never heard his name. In the years before blood pressure medication existed, a diagnosis of malignant hypertension, which just means severely elevated blood pressure, was essentially a death sentence. Patients went blind from retinal bleeding. Their hearts enlarged from the strain. Their kidneys failed. There was nothing to do. Dr. Kempner, working at Duke University, decided to try something radical. He put his patients on a diet of nothing but white rice, fruit juice, and a small amount of sugar. 0 salt, 0 fat, almost no protein, nothing else. In 4 weeks, some of his most severe patients saw their blood pressure drop from readings like 200/120 down to 120/80. Retinal bleeding healed. Enlarged hearts shrank back toward normal size. Kidneys recovered function. Patients who had been given months to live walked out of his clinic. Now, I am not telling you to eat white rice and fruit juice. The diet was extreme, and there are much better ways to achieve the same result today. But what Dr. Kempner proved was that the primary driver of elevated blood pressure, the thing his diet was eliminating almost entirely, was sodium. And more specifically, it was the ratio of sodium to potassium in the diet. The cells in your artery walls maintain their flexibility through a careful balance of sodium and potassium. When sodium is chronically high and potassium is chronically low, as it is in the typical American diet of processed foods and fast food, the artery walls stiffen, the smooth muscle contracts, the vessels narrow, pressure climbs. Dr. Kempner's patients were not mild cases. These were people who had already gone partially blind from the pressure. People whose hearts had enlarged so much that the chest X-ray looked wrong. People whose kidneys were failing. The medical establishment of the time had essentially told them to get their affairs in order. Within 4 weeks of the rice diet, some of them could see again. The retinal bleeding had stopped. Not slowed, stopped. The heart size visible on the X-ray had begun to shrink back toward normal. The kidney function was recovering. Dr. Kempner was not celebrated for this. He was viewed with deep suspicion. The mechanism was not understood. A diet of white rice and fruit curing what was considered an irreversible disease made no sense within the framework of how medicine understood blood pressure at the time. He was an outsider with strange ideas and inconvenient results. Sound familiar? The sodium-potassium story he accidentally proved has since been confirmed by decades of research. The DASH diet, the dietary approaches to stop hypertension, which is now one of the most evidence-based dietary patterns for blood pressure management, is essentially a refined, livable version of what Kempner demonstrated in extreme form. High potassium from fruits and vegetables. Low sodium. The ratio matters more than either number alone. The modern equivalent of what Dr. Kempner proved is not a rice diet. It is a conscious, specific shift in the sodium-potassium ratio every single day. More potassium, less sodium. Not as a vague suggestion, but as a precise daily intention. Before I give you the full protocol, I want to say something directly to the people watching who are on blood pressure medication and are now feeling worried. Do not stop your medication because of this video. I am not telling you that blood pressure medication is wrong. I am not telling you that lowering blood pressure is dangerous. What I am telling you is that the target number matters, the bottom number matters, and the combination of blood pressure medication with other medications you may be taking matters in ways that a 15-minute appointment may not always catch. The goal of this video is not to make you distrust your doctor. Your doctor is on your side and is working with the information available to them. The goal is to give you better questions to bring to your next appointment. Specific, informed questions that change a 15-minute general checkup into a 15-minute targeted conversation about your specific numbers, your specific medications, and your specific risk profile. The question that changes the most is this one. Doctor, what is my pulse pressure and what is my diastolic number at its lowest point across my last 6 readings? If the answer involves a diastolic consistently below 60, you have just opened a conversation that matters enormously for both your heart and your brain. That conversation is worth more than anything else in this video. Now let me give you the 4 natural interventions, not as replacements for your medication, as additions that work with your aging arteries directly, addressing the stiffness and the inflammation and the microscopic damage at the vessel wall level that medication alone never reaches. If you want the complete guide with exact dosages, timing, and the full research reference list, it is in the ebook. The link is in the description. But stay with me because everything I am about to give you is actionable this week. The first intervention is hibiscus tea. Hibiscus contains compounds called anthocyanins, specifically one called delphinidin, that act as natural ACE inhibitors. ACE inhibitors are a class of prescription blood pressure medications. Lisinopril is the most commonly prescribed one. The mechanism in hibiscus is the same. It relaxes the smooth muscle in the artery walls. It reduces the resistance that blood has to push against. A study published in the Journal of Nutrition showed that 3 cups of hibiscus tea per day lowered systolic blood pressure by 7.2 points. That is comparable to a low-dose prescription medication. Not identical, not a replacement, but a measurable, consistent, documented effect from a tea you can buy at any grocery store. The preparation matters. Steep it for 5 to 7 minutes, not a quick dip of the bag. 5 to 7 minutes pulls the active phenols out of the flour. A quick steep gives you colored water. A proper steep gives you medicine. One caution. Hibiscus acts as a mild diuretic, which means it increases urine output. If you are already on a diuretic medication like hydrochlorothiazide, combining them is essentially doubling up. Monitor for dizziness, especially when standing, and discuss with your doctor if you are on a water pill. The second intervention is pomegranate juice. Pomegranate blocks serum ACE activity by 36%. It also prevents the oxidation of LDL cholesterol inside the artery wall, which is one of the primary drivers of plaque buildup. 2 to 4 ounces daily mixed with water. Not a full glass of straight juice, particularly if you are managing blood sugar, as the sugar content adds up. 2 to 4 ounces diluted with water gives you the therapeutic effect without the sugar load. Important medication interaction. Pomegranate juice affects your liver the same way grapefruit juice does. It blocks an enzyme called CYP3A4 that breaks down many medications, including statins like atorvastatin and simvastatin, and some blood thinners. If your medication bottle has a warning that says, "Do not take with grapefruit juice," that same warning applies to pomegranate juice. If you are on a statin or a blood thinner, speak to your doctor before adding pomegranate to your routine. The interaction can increase the medication's potency beyond safe levels and cause serious side effects, including muscle damage. The third intervention is taurine. Taurine is an amino acid found in high concentrations in dark meat chicken, turkey, and scallops. Most people have heard of it in energy drinks, where it is usually combined with caffeine and sugar and given to young people in large cans. That is not what we are talking about here. In your artery walls, taurine increases the production of a gas called hydrogen sulfide. That sounds alarming. It is not. Hydrogen sulfide is a natural compound your body produces that relaxes the smooth muscle surrounding your blood vessels, in the same way nitric oxide does from beets. It is a different pathway to the same outcome: open pipes instead of narrow ones. A study published in the journal Hypertension in 2016 showed that 1.6 grams of taurine daily reduced systolic blood pressure by 7.2 points. A serving of dark meat chicken or turkey provides a meaningful amount. If you prefer a supplement, 500 milligrams to 1 gram daily is the range used in most cardiovascular research. The fourth intervention is vitamin K2, and this one addresses something that almost nobody over 65 has been told about the calcium supplements and vitamin D they have almost certainly been told to take. When most seniors hear they need more calcium for their bones, they take a calcium supplement. And when they hear vitamin D helps absorb calcium, they take that too. This is standard, reasonable advice. But there is a step that is almost universally left out of that conversation. Without vitamin K2, the calcium that vitamin D helps absorb has no direction. It goes into circulation, and calcium in circulation finds its way into artery walls. This is called arterial calcification. It is one of the primary drivers of arterial stiffness. The very stiffness causing the wide pulse pressure, the non-dipping, the brain hypoperfusion, and the diastolic danger zone. Vitamin K2 activates a protein called matrix GLA protein. Think of matrix GLA protein as the traffic director for calcium. It takes calcium out of the artery walls where it does not belong and directs it into bones where it does belong. K2 does not just prevent the problem from getting worse. It actively works to reverse existing calcification over time. The best food source is a Japanese fermented soybean dish called natto. 1 tablespoon contains about 150 micrograms of the MK7 form of K2, which is the most bioavailable form. I will be honest with you about the taste. Most Americans describe it as having the texture and smell of something that has been in a gym locker for 6 months. If you are willing to try it, your arteries will thank you. If you are not, and most people are not, the supplement form is perfectly effective. Look for MK7, not MK4. MK7 stays active in the body significantly longer. Critical safety note: if you are on warfarin or any blood thinner, do not take vitamin K2 without your doctor's approval. Vitamin K in any form affects how blood thinners work, and your INR needs to be monitored if you add K2. This is not optional. This is a conversation your doctor must be part of. Comment below and tell me which of these 4 you are going to try first. And tell me if anyone has ever mentioned pulse pressure to you at a doctor's appointment, or whether today is the first time you have heard that number. Now I want to tell you about something that is lining your artery walls right now that most people have never heard of, and whose absence explains why blood pressure damage happens the way it does. Imagine your arteries are lined with a microscopic fur coat, not visible to the eye, not visible on any standard test. A layer of tiny, hair-like structures made of sugar chains and proteins that coat the inside of every blood vessel in your body. This layer is called the endothelial glycocalyx, and it is the most important structure in your arteries that medicine almost never discusses. This fur coat does several things. It prevents blood cells and clotting factors from sticking to the artery wall. It regulates how nitric oxide is produced by the endothelial cells. It acts as a shock absorber against the pressure of each heartbeat, protecting the delicate vessel wall from the mechanical force of blood flow. When blood pressure is chronically elevated, the force of blood moving through the arteries is like a lawnmower going over that fur coat. It shears it off. The smooth surface becomes rough. Clotting factors stick. Inflammation starts. Plaque begins to form. The vessel stiffens further. Compounds found in seaweed and in hibiscus tea have been shown to support regeneration of this glycocalyx layer. Sulfated polysaccharides, which just means certain sugar chain structures found in marine plants, appear to support the rebuilding of this protective coating. Hyaluronic acid, which most people associate with skin creams, is also a component of the glycocalyx, and supplementing it may support its restoration. Here is a practical way to think about why the glycocalyx matters for seniors specifically, and not just for people with diagnosed hypertension. Every time your blood pressure spikes, even temporarily, even the spike that happens when you stand up too fast from your recliner, the mechanical force of that spike is hitting the glycocalyx. A single spike does not destroy it. A decade of spikes, of uncontrolled hypertension, of blood pressure managed but never actually addressed at the arterial wall level, wears it down progressively, like waves against a sandcastle. Once the glycocalyx is thinned, the artery wall beneath it is directly exposed to the friction and chemical stress of blood flow. Inflammation starts there. Plaque builds there. The vessel stiffens there. And the stiffening of the vessel raises the blood pressure further, which sends more damaging force against an already weakened glycocalyx. This is the cycle that aging arterial walls are caught in. The hibiscus and the taurine and the K2 and the pomegranate each address different points in this cycle. None of them addresses everything. Together, they address the cascade at multiple points simultaneously, which is why the combination matters more than any single element of it. This is early-stage research compared to the other interventions I have described. I include it because the glycocalyx is the missing piece of the puzzle that connects blood pressure damage to inflammation, to plaque, to clotting in one continuous chain. Understanding it changes how you think about what blood pressure does to your arteries beyond just the pressure numbers. Let me give you the protocol. Organize simply because the goal is something you can actually follow every morning and evening. Morning with breakfast. Vitamin K2 as MK7, 100 to 200 micrograms. Take it with food since it is fat-soluble and absorbs better alongside dietary fat. If you are on warfarin, skip this until you have spoken to your doctor. Mid-morning or with lunch. Taurine, 500 milligrams to 1 gram. Dark meat chicken or turkey at lunch is a food-based alternative. Scallops twice a week contribute meaningfully. Afternoon. 2 to 4 ounces of pomegranate juice diluted in water. This is your artery pipe cleaning window, away from meals to avoid adding to mealtime sugar load. Evening. 3 cups of hibiscus tea steeped for 5 to 7 minutes. This is your natural ACE inhibitor working during the hours when non-dipping is most likely to occur. The mild diuretic effect also helps reduce overnight fluid volume, which supports the nocturnal dipping your arteries need to rest and repair every day. The sodium-potassium ratio. Not a supplement, a daily food habit. More potassium from avocado, leafy greens, and beet tops. Less sodium from processed and restaurant food. Dr. Kempner proved in the 1940s that this ratio alone could drop a reading of 200 over 120 down to 120 over 80. The modern version does not require white rice and fruit juice. It requires knowing which direction to push the ratio every single day. Critical safety note on potassium. If you are on an ACE inhibitor, like lisinopril or enalapril, or if you have stage 3 or worse kidney disease, your body holds on to potassium instead of excreting it normally. Do not increase your intake of high potassium foods like beet tops, spinach, or avocado without first checking your potassium blood levels with your doctor. Elevated potassium, called hyperkalemia, can cause dangerous heart rhythm problems. The sodium-potassium advice applies to people with normal kidney function who are not on ACE inhibitors. If either of those applies to you, speak to your doctor before making dietary changes around potassium-rich foods. Do the active stand test this week. Sit for 5 minutes. Take your reading. Stand up. Take it again immediately. If the systolic drops more than 20 points, bring that information to your next appointment. Not as an alarm, as data. As the specific finding that opens a specific conversation about whether your current dose is right for where your blood pressure actually is when you move through your day. Let me give you the week-by-week picture of what to expect, because knowing what is coming prevents you from quitting before the biology has had time to respond. Week 1. The hibiscus tea is the fastest-acting element. Some people notice a small improvement in morning blood pressure readings within the first week. Do not expect dramatic change. Look for direction, not magnitude. A reading that was 148 and is now 144 is a direction. That direction across 30 days tells the real story. Week 2 to 3. If you are a non-dipper, the most noticeable early change is often in nighttime bathroom trips. From 3 or 4 times down to 2. From 2 down to 1. This is the kidney pressure response beginning to normalize as the evening hibiscus protocol supports the nocturnal dip your arteries need. Week 4 to 6. Take your reading morning and evening and calculate the pulse pressure gap both times. If the gap is narrowing, the arterial stiffness is beginning to respond. Arteries do not soften quickly, but the direction of change across 6 weeks is the measurement that matters far more than any single morning reading. 3 months. Ask your doctor to recheck your full panel and bring your home monitoring log. A doctor who sees 30 days of home data understands your blood pressure in a completely different and more useful way than one who has 3 office readings taken under artificial conditions. Let me also tell you about the one test most people have never had done that would tell them more about their cardiovascular future than almost any other single measurement. An ankle brachial index is a test where blood pressure is measured at the ankle and at the arm at the same time. The ratio of those 2 numbers tells your doctor how well blood is flowing through the peripheral arteries, the vessels in your legs that are often the first to show the effects of arterial stiffening and calcification. A normal ratio is above 0.9. A ratio below 0.9 means the arteries in your legs are narrowed enough to reduce blood flow. This is called peripheral artery disease, and it is almost always present in the same person who has stiff coronary arteries and a wide pulse pressure. Most seniors have never had this test. It takes 5 minutes, it costs almost nothing, it does not require a specialist. And the result tells you and your doctor whether the arterial stiffness we have been discussing is systemic, present throughout your vascular system, or localized. Ask for it at your next appointment. Alongside the pulse pressure calculation and the standing blood pressure test. 3 simple measurements that together give a picture of your vascular health that no single blood pressure reading in a doctor's office ever could. One more thing before I close. Something for the people watching who have a spouse or a parent or a friend who they have been watching change slowly, the way Dorothy's daughter watched her mother change, and who have not known how to name what they are seeing or what to do about it. Print this out, or write down 3 things: the pulse pressure formula, the active stand test, and the question to ask the doctor about the diastolic number across the last 6 readings. Hand it to the person you are worried about and say, "I watched a video and I want you to take this to your doctor." You do not have to explain the whole thing. The 3 pieces of paper do the work. That is how good information travels. Not from a clinic to a patient in a 15-minute appointment. From one person who found something useful to the person they love. Dorothy came back to see me 4 months after we adjusted her medications and she began the protocol. Her new target was 135/68 instead of 118/58. She had been skeptical at first. 11 years of being told lower is better does not change overnight. She sat across from me and said, "The words are coming back." Not all of them. Not all at once. But in the previous 4 months, only twice had she hit that gap in a sentence where the word should have been. Twice in 4 months, compared to several times a day. She had not fallen once. She still woke up once at night to use the bathroom, instead of 3 or 4 times, and she had found her car keys in the same place 2 mornings in a row, which she told me with a precision and a quiet satisfaction that made the room feel different. She asked me why nobody had told her about the bottom number before. I told her the honest answer. The guidelines were written before the data on seniors existed at the level it does now. The system is catching up. The 2026 consensus has changed the conversation, but it takes time for that conversation to reach every 15-minute appointment in every clinic across the country. And in the meantime, the patients who know to ask the right questions get the right answers faster than the ones who are waiting for the system to catch up on its own. She nodded. She picked up her reading glasses and her crossword puzzle from the chair beside her, and she walked out of the office without hesitating at the door. I want to add one more subscribe reminder here, because what I am building on this channel is specifically for this. The intersection between what the newest medical research says and what actually reaches the people who need it. Most of the information in today's video exists in journals and in specialist conversations. It is not hidden. It is just not making the journey from those journals to the 15-minute appointment fast enough to protect the people sitting in the waiting room right now. Subscribe so you do not miss what is coming, because the next video continues this conversation. Now let me go a little deeper on the J-curve before we close, because I want you to understand it in a way you can explain to your own doctor if needed. Picture a simple graph. The horizontal line across the bottom represents blood pressure, going from very low on the left to very high on the right. The vertical line going up represents your risk of a cardiovascular event, a stroke, a heart attack, a fall that leads to a hip fracture. When blood pressure is very high, risk is very high. As pressure comes down, risk drops. This is the well-established part. This is what every blood pressure guideline is built on. But the J-curve shows that once blood pressure drops below a certain threshold, the risk line curves back up again. The J shape. Risk goes down, reaches a low point, and then starts climbing back up as pressure gets too low. For the top number, systolic, that danger zone for seniors is below about 120. For the bottom number, diastolic, it is below 60. Below 60 diastolic, and the heart cannot feed itself properly during its resting phase. Below 120 systolic in a 75-year-old with stiff arteries, and the brain cannot receive adequate blood flow against gravity to the deep white matter. The safest place on the J-curve for most people over 70 is not at the very bottom. It is slightly to the right of the bottom. A range, not a single target number. For most people over 70, that range is 130 to 140 systolic and 65 to 80 diastolic. Wide enough to protect the heart and the brain. Low enough to reduce the risk of stroke from hypertension. This is what Dorothy's doctor did not know to tell her. Not because he was a bad doctor, because he was following a target number from a trial that did not include people like Dorothy. The 2026 consensus has now given clinicians clearer guidance for older adults specifically. But it takes time for a consensus to change what happens in every clinic across the country. You now know it. Bring it with you. The question that opens the conversation is simple. Doctor, given my age and my current readings, are we managing my pressure to a target number or to a target range? And what are my diastolic readings telling us? That question, asked calmly and specifically, is the difference between a 15-minute appointment that confirms the same plan you have been on for 11 years and one that opens a genuine reassessment. Dorothy asked it. 4 months later, she found her car keys in the same spot 2 mornings in a row. The words came back. Not all of them, not all at once, but enough to finish a sentence without losing the thread. Enough to sit at the kitchen table with her crossword puzzle and feel like herself again. That is what the right number feels like from the inside. Comment below and tell me if anything in this video named something you have been experiencing but could not explain. The night bathroom trips, the word gaps, the morning dizziness, the numbers that look great on paper but leave you feeling like something is wrong. Tell me how long you have been dealing with it. I read every single comment, and your story helps every other person watching who is looking for the same answers you found today. If this video explained something your doctor has not had time to cover in a 15-minute appointment, please hit the like button and share it with someone over 65 you love who is on blood pressure medication and has been told their numbers look perfect. The numbers are only part of the story. They deserve to know the rest. Everything in this video is for educational purposes only. It is not medical advice, and it is not a substitute for your doctor's guidance. Do not change or stop your blood pressure medication without speaking to your doctor. Blood pressure management requires medical supervision. Bring this information to your doctor as a starting point for a conversation, not as a reason to make changes on your own. The complete protocol with every dosage, every study, every safety warning, and the full interaction checklist is in the ebook. The link is in the description below. I will see you in the next video.